My name is Shamika Davis, and I'm a program manager at the School-Based Health Alliance. I would like to share with you about the School-Based Health Alliance. The School-Based Health Alliance is a DC-based nonprofit founded in 1995 and serves as the national voice of school-based healthcare. Our focus includes policy, standards, data, and trainings to support and grow school-based healthcare, particularly school-based health centers. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack equitable access to healthcare services. School-based healthcare is one solution, bringing healthcare to where students typically spend the majority of their time in school. When students, families, schools, and the community work together, students win. A few reminders for today's webinar. All attendees are in listen-only mode. To ask a question during the session, please use the Q&A function. Closed captioning is enabled for this session. To turn it on, please click the CC button on your Zoom control panel. At the end of today's session, we invite you to complete an evaluation of the webinar. Also, a copy of the slides and today's recording will be sent to you by email in the upcoming days. Our objectives for today's integrated mental health webinar are to identify best practices in strengthening partnerships and care coordination in school-based health centers, to identify ways to incorporate evidence-based care strategies into school-based healthcare and ideas around measuring these practice outcomes, to define how implementing telehealth care in school settings is a way to improve students' access to care. I am happy to introduce our speaker for today, Caitlin Warner, Senior Regional Director, Behavioral Health, School-Based Health Center at Community Health Center, Inc. Caitlin is a licensed professional counselor and earned her master's in counseling at Ashbury Theological Seminary and her bachelor's in healthcare administration at the University of Central Florida. She is a trust-based relational intervention practitioner, and she is trained in several evidence-based practices, including trauma-focused cognitive behavioral therapy, EMDR, and acceptance and community commitment therapy. She is passionate about providing quality mental health care to children, adolescents, and families in underserved communities, as well as leading the School-Based Health Center program at Community Health Center. Prior to coming to Community Health Center, Caitlin worked for a nonprofit bringing quality mental health services to orphan and vulnerable children in developing countries. In that role, she developed programming, provided crisis intervention, and trained staff and caregivers in trauma-competent caregiving. Since joining the health center, she has continued her passion in educating others on working with children with trauma through leading professional development seminars in her school district, as well as taking part in educational webinars at the health center. I now welcome Caitlin Warner. Caitlin.
Thank you so much for that warm welcome. I'm going to take a second and just pull up my slides for today. Again, my name is Caitlin Warner and I work for Community Health Center. Our school-based program is part of our bigger system as a whole. So I thought just as I start to dive into some of this and my experience in school-based, I'd share a little bit about our organization so you kind of know where we're coming from. Community Health Center was founded in the 70s by Mark Maselli and a group of college students out of Wesleyan University and community members in Middletown, Connecticut, after kind of realizing there wasn't a lot of quality healthcare available to those in the underserved population. Mark really believed that healthcare is a right and not a privilege, and kind of out of that, CHC was born. We started with just a few sites, a couple dentists that volunteered, a doctor here or there, and we've grown to providing healthcare all over Connecticut. This is a picture of everywhere, the towns that we have kind of our main fixed sites in. So part of our agency is a fixed site that has everything from behavioral health to dental to medical care. And you can kind of get all of your health needs met through this agency. And we're strategically kind of in underserved areas. School-based kind of joined the picture at CHC in the 90s. School-based over the country was kind of taking more root. And CHC really saw the value of having kind of practitioners and people in places kids were already at. We started in a school in Middletown with one nurse practitioner, and it gained traction. And so over the 30 years we've been doing this, so now we've grown to we're in 180 schools in Connecticut. This is the most recent map I was able to find. It kind of shows where we have different services. Some of our school districts, we provide the whole gamut. We have medical, we have dental, and we have behavioral health. Other areas, we might only have dental or we might only have behavioral health. And we really make those decisions based on what the school is coming to us asking for and what they feel like their population needs and what services are kind of available in their area before we step in to kind of help see what the need in the community is. As we start to talk about the idea of building partnerships, I thought we would kind of focus on it in 3 different ways. First, talking about how do we first even get involved in a school, because our partnership with the schools really does start there. And then we'll look at what do we do kind of in the beginning, initial stages when we're first opening a health center in a school, and then how do we continue to deepen and build those partnerships moving forward after it's already been established. So first is how do we even get in? At CHC, because we've grown so fast and are in so many schools, they often use the word grassroots approach. We have never really called schools, districts, or cold called and tried to find ways in. It really has been a word of mouth. Sometimes it looks like superintendents talking to each other or principals sharing with each other the services we're providing, and through that, we have kind of spread. Another main way we get into schools is when there's a tragedy within the community. Oftentimes, those are the moments where communities kind of realize the need for mental health and medical services, and that is often our door in. For example, the article on the side is from a suicide that happened in Enfield, Connecticut, which is actually where I practice now. And we had been in we'd been in the high school and middle schools for years, but not elementary yet. And then once we had a suicide in the elementary, the school district kind of realized we need services for younger kids too. And then we quickly moved into the elementary schools as well. Sometimes we have school staff or CHC staff that kind of refer school districts to our program. So that's another way we can get in. We've had times too where health departments or the state has asked us to kind of step in due to lack of resources in that area. We have some schools that are kind of rural, and there aren't a lot of providers out there. So sometimes that is a reason we go into schools. And then whenever we're looking at a school district and will we go in or not go in, we look at does it align with our mission. CHC's mission is to provide that quality care in underserved communities. So do they meet those needs? Like, is there an underserved community that doesn't have other providers? So we might look at things like the amount of free and reduced lunches, the amount of children on some type of Medicaid or state aid, and how many other providers are around. Because if there's need there, we'd rather support the providers that are already there versus coming in if that's an option. And then kind of how do we begin? So once a school has invited us in, we've identified we're going to move forward, we kind of have our programmatic staff that kind of take over at that point. And they begin laying the foundation. I feel like this is a really important part of the process because this done well kind of helps everything be smooth as we start to bring medical providers or therapists or dentists into our buildings. They handle everything from kind of starting to identify who are the key relationships in the school. A lot of our work is about building relationships in school. So who are the people that we kind of want to focus on initially and kind of get some buy-in with them? They also handle a lot of the things that may seem small, like office setup or making sure things are in the right places, but that really does help. Having that set before we have providers walk in just helps with a smooth transition around building those relationships. And then they begin to start to tell families about what we do and about what we can offer, and we start to open up our enrollments for people to join. once that kind of happens, we start kind of what do we do when a provider is ready to go in the building? I always start with kind of setting the tone, reminding our providers, reminding our staff that we are guests in the school building. This school has been there, it's been operating long before we've ever entered the picture. So how do we like honor and kind of come in with that humility around this is something we want to join you in. I feel like that attitude really can help set the stage for building positive relationships with schools. I've seen it at times where maybe therapists come in feeling like they maybe know more or have something different, and that is a way to kill a relationship with a school from the beginning. We then try to make sure that the staff or providers are introduced to the key people and kind of, again, always remembering building that relationship is first. It could look like the administration, obviously, are important to get to know your relationship with. I always remind staff too that kind of the keys of the school are the school secretaries. So building that relationship with your school secretary is going to be huge. Not only can they help you if you need something and you don't know how to figure it out in the building, but they really are the people that kind of gateway for the teachers or gateway for the other staff. And so building that relationship with them is huge. If your school is big enough to have a guidance staff and a guidance secretary, that person is key too. And then I also look to get to know the teachers that have buy-in to mental health. Some of our schools are so big that it's hard to get to know every teacher initially from the jump. But I've found in the times that I have open schools or coached other staff that people who really buy into the program make themselves known. They'll come and find you. They'll hang out with you. They'll ask questions. So really focusing on building those relationships. We also be strategic about making our presence known. We show up at open houses, school events like that, and we bring our resources and things we can get to know. People can get to know us. We show up for conference nights or things like that where we can be in the building. Sometimes I coach staff if they're really struggling to kind of integrate, to maybe have their lunch in the staff break room, find ways to kind of be a part of the community as much as possible. I always encourage people to leave their doors open if they're not in session with a kid so that people can see that you're there, that they can stop by, they can check in. And then I kind of have my best practice tips I give staff that come in, because I know that while I love first setting up a school-based health center like that, this piece of the work really I enjoy, not every staff does, and some are nervous. So making sure that they have support and some coaching going into the building. Some of it is the things I mentioned before, but some of it is things too, like I always talk about, joining in, finding out what's important to the school and joining in. So whether that's buying the school t-shirt and wearing it on Fridays with the rest of the staff, or whether that's, if you're invited, participating in the Secret Santa or the Boograms or whatever type of staff morale thing they're doing, as you're able to, joining into that. I also have always encouraged an open door policy for teachers, making it a place, letting teachers know you can come by and stop by my office. Obviously, I can't share information about my clients necessarily, but if you want to just run a question by me, like how do I manage this in a classroom, or you just need someone to listen, kind of having that open door policy will help teachers begin to get to know you and trust you. I also encourage my therapists to be genuine. When you're in a building, be yourself. People are drawn to that. I think if we're trying too hard or it isn't genuine, people know and they pull back. I also share with everyone that people love food. So any type of event you can bring food or provide food, it tends to also go well. We've had other times we've had staff who send out letters to families or put a blurb in the school newsletter, kind of introducing themselves, making their presence a little bit more known. Those are ideas that have kind of really helped us get off the ground and running in some of our schools. So now we've been in the school for a little bit, we've gotten going. How do we continue to deepen this relationship? Some of our districts we've been in for a long time. And I think it's easy to lose sight of that. We continue to need to always build and deepen the relationship. Some of the biggest things I do with our managers over schools is talk about, like, how do we be proactive? How do we identify the issues that are happening in schools? maybe there is a school we're dealing with that has a huge bullying issue. Is there something we can do to kind of help with that? Can we offer, a training? Can we offer conversations with staff? Or we might have another school that's maybe having an issue getting along with one of our providers. Like, how do we step in and continue to show that we are on top of it, that we care about what you care about, and that we are going to be involved in this as much as you are? A big way we do this is getting to know, as you're building these relationships, what the goals of the school are. If you talk to any administration, they're going to tell you that they have goals, things they want to work on. Sometimes I might hear it as, we want to improve attendance, or we're having a big attendance issue in our school. So what can we do to help be a part of that, or be aware of that being an issue? Overall, school-based health centers have shown to improve attendance, but how do we communicate that with them? What can we do to be a part of it? Or an issue might be, we're struggling with a lot of substance abuse issues. What are some things we can kind of do to join them? Most schools have to have professional development days. And from having teacher friends and being in schools now, a lot of what I hear is, we have one on mental health a year, and it's usually the same thing every year. An overview of this is what trauma is, this is what abuse is, you should call DCF, and that's it. But not something that's really practical, or like, how can I help manage dysregulated kids in my classroom? How can I help be a safe adult to kids? Like, more practical skill sets. So I think that's something that we have been able at the health center to then offer, like, what are the things you're struggling with or your staff wants more education on, and how can we help you in real ways? We also at the health center have supported in crisis, whether we have a death in a school, or we had recently a family whose house burned in a fire. How do we kind of help have providers available? So often if we have a major crisis like this happen in a school, we will send a team of providers to that school to be a part of the crisis response. And then every year, at least annually in some of our more established districts, but more often in our newer ones, we have stakeholder meetings. Oftentimes that's the superintendent, sometimes the Board of Ed, principals, administration, and we get together and we sit down and we talk. What's working for you? What's not working for you? What are you seeing happen? What do you need more of? Oftentimes we'll share the data. We'll share, this is how many visits that we've had this school year. This is how many students in your district that are enrolled. These are the amount of times we've had to refer out to the hospital. These are the amount of times that it was a close referral, but we were able to not go that route, and share that so that there is measurable ways that they're seeing that our program is bringing something to their school district. I want to talk about care coordination for a minute, just because I think this is huge in schools. We rely a lot on them in school-based centers for coordinating little things, even getting a student from class to your office. So I think at the jump, we try to be really open about expectations and boundaries, both with the families working with schools, and with our staff. I think a lot of times there's questions that'll come up with, how much are you going to share with the school? What are you going to do if this is told to you? So we try to just be really clear about that from the beginning. And then obviously those can also be ongoing conversations. We do ask all of our families to sign a release of information for the school. This does not mean that we then share with all of the school what that child is going through. But this does allow us to call into classrooms and request a student to be brought down. Or if a parent asks us to go with a student to guidance and talk about an issue, obviously we train our staff to really on HIPAA and being aware, but this allows us to kind of have a little more access. We do attend 504 IEP meetings as invited. Sometimes the school invites us, sometimes the parents invite us, but I think that helps us kind of connect what the student's experiencing in school to what they're working on in therapy. And then within our own organization, or referring to medical providers, we are an integrated health system. So we have an integrated electronic health record, meaning that any providers within our system who's linked to that patient can look in their record and see what is going on. And so if I have a student who is seeing one of our psych providers, I can look in their record and see, what medication they were given, or if they're saying they're complying or not with their medication. Because if I ask the student, sometimes, I get the answer, I don't know, like the white pill or the green pill, but to be able to go in and see it, or the psychiatrists can go in and see my notes from our last session, or see how many times the student has come, or if the student is no-showing to our sessions a lot, they're able to see that. The same with any type of medical provider in our system can see. We're also able to refer to the providers ourselves and schedule with them. So if I have a student who I know needs a psych eval, I'm able to go into our system, refer the patient, set up the appointment myself. And we really do that for ease for the patient, right? If I've got the mom on the phone and can schedule the appointment, that's a lot easier than telling mom to call a different number and hope someone answers and then schedules them. So that's part of how we also navigate that. Evidence-based care strategies that we use in our school-based health centers. So obviously evidence-based care is super important in the work we do. We want to be doing work that helps kids get better. And so we place a high importance on this type of training for our clinicians. Every initial interview, that's a question that's going to be asked of someone. We ask what evidence-based cares they're already trained in, or if they're not trained in one, what would they want to be? What are they interested in? CHC also gives all of our clinicians a pretty generous amount of money every year for ongoing training, as well as 4 days to go and get trained. So we've had people go on and get trained in EMDR or DBT, a lot of different avenues. It's kind of up to the provider what they're seeing as the needs in their school, what they're interested in. We've also been building out work groups and supervision groups for each of these evidence-based models. Currently, we have one for TFCBT, and we're working to build our EMDR one right now, but so that providers who are trained in them have a meeting. Usually it's either once a month or once every other month where they can get supervision, specifically in that model. They can review cases together. We also, again, we use our stakeholder meetings as time to share some of those evidence-based care data we're pulling together. And we provide patient satisfaction surveys in all of our schools every year. A lot of times we do this by sending iPads to the schools that the kids can fill the surveys out right there after their session. We also send links to families. We found we tend to get more of a response if we have an iPad there or something this child can do it on right away. But we do send it out so parents can fill out as well. And then the next kind of biggest evidence-based care thing that we've done in the last probably year and a half is we've moved towards using measurement-based care across the whole agency, including school-based. We do it through a program called MIRA. So what this is MIRA sends out to all of our clients different measures that can be filled out. Obviously, with a population with younger kids, we have measures that go to the parents and we have measures that go to the student. Once they're enrolled in MIRA and an appointment is scheduled, the measures are sent to them. We then as therapists get the results back and we can review them before our sessions, which is really helpful because they ask questions around things like symptoms. And we can kind of watch and track, are symptoms getting better? Are they getting worse? They ask like how effective the child is feeling like therapy is. And it gives room for them to kind of say what they're needing more of or what they're needing less of. You know, there's questions around the therapeutic alliance. And survey fatigue is something we absolutely deal with our patients sometimes. But what I like about MIRA is that as it sends out the initial survey, which is a little bit longer, it sends out shorter ones in the follow-up. So that way people can just fill out kind of and answer questions around the symptoms and the things they've already identified as an issue. MIRA's also helped us with our compliance around obtaining Ohio scales. Some of the areas we're in based on funding, we need to have families fill out Ohio's. And sometimes that can be hard to chase people down and get them done in time, but MIRA sends them out for us and we'll send reminders to the family so that we can hopefully get them filled out and get them back in the timely manner. As we've looked at how do we increase our access to care, we've grown so much and there's so many students in need. And I'm sure all of you have felt it too. Post-COVID, the focus on mental health has just been huge. And the need is more prevalent and more people are more aware than they probably have been in the past. So part of what we've done is we've worked on making the process of enrolling really easy. We still do our intakes with parents and everything, but before we used to have paper forms. We've moved away from that. We do have them for people who don't like technology, but we do have a website people can sign up on, as well as a QR code that people can scan and enroll their child right from their phone. Another major move we've made in the last year. And I'll admit it's been controversial at times in our agency, is to hire pre-licensure staff. So people who have completed grad school, are registered with the state somehow, and are working on their hours towards licensure. Historically at CHC, we have had kind of a residency program for our nurse practitioners and our doctoral candidates. And we are building that right now for pre-licensed staff so that we can kind of have them involved, as there's been obviously a nationwide shortage of therapists and behavioral health providers. So that's been something we've moved towards in the last year. We also do a lot of group therapy in school-based. I personally love groups, so it's easy for me to promote this one because I find they can be really valuable. But this is a way we are able to kind of get more kids involved and on more caseloads at times. And then we use telehealth. I'll talk more about kind of our history with telehealth, where we've been and how we're using it now in a second, but that really has opened up our ability to help kids. Sometimes we might have a kid in a school who needs a certain type of provider or a certain skill set in another school. We've been able to use telehealth to help have that met. And so thinking through telehealth, I'll share a little bit of the history we've had with it. So within probably 3 days of schools closing with COVID, we were able to jump into telehealth. Now, part of that was because our agency obviously didn't know about COVID, but we knew telehealth was coming in the future, and it was something we would utilize. So the back end work had already been happening. We do use Zoom. We have the wait room and the ability for therapists to add people and have people leave so that it's HIPAA compliant. But every therapist has their own Zoom room that they can see patients in. Initially, when it started right at school, it wasn't super popular. Everyone was really concerned, how do we work with students on this? So we really built a lot of work groups around coming up with creative therapeutic interventions to use over telehealth. We had another work group that worked with schools on how to get kids devices that didn't have devices, or how to help them get internet connection if they didn't have internet connection. Because our goal was really, how do we continue to give these kids the quality of care now that we're in the middle of the crisis? Since then, we've continued to utilize telehealth. It's not going away. I think we all probably are aware of that. And we use it in a couple different ways. A lot of our therapists use it over the summer when school's not in session to be able to still provide care for the kids. Our therapists that see younger kids will still often like to go into the schools over the summer, but a lot of our older kids would rather just hop on a Zoom call. It helps ease for the parents. They don't have to try to get them there if a kid's home. We've been able to do telehealth really well that way. We also use it if a kid is either suspended and out for a while, if they're homesick. And we've used it at times too if a provider's homesick. Maybe they have COVID, but they're feeling well enough to see patients, but can't go into the school, and we don't want to disrupt services that long. So if they have somebody able to kind of help with the logistical piece, we will use telehealth with them. With that, we've really looked at how do we do that in schools well. A lot of our schools, the kids cannot download Zoom on their Chromebooks or iPads. It's one of the block sites. So we've moved towards using either locked iPads or locked screens, meaning that they cannot get on any other part of the internet or anything. They can only use Zoom on that device. And so we've worked to kind of put that in our schools where we are using telehealth. I'll be honest, there's only a couple we're doing right now. We're testing it more to see how it'll work big picture. And some of that is because there are barriers and considerations. If you're going to use telehealth in a school where the student is there and the provider is not, obviously there are rules around that, right? Like we can't just put kids in a room alone. So we have to have somebody who's there who's able to kind of help coordinate bringing the student down, monitoring them during session, and bringing them back to class. But we also have to coordinate like who is our contact in the school. If we're meeting with a student and they start to tell us they're suicidal or start to tell us they're concerned, we have to have a relationship with someone there to kind of make sure that everything safety-wise is followed through with, because we do follow all of the school safety recommendations and needs as part of that. So that is what I wanted to share with you today. I wanted to make sure we left enough time for any questions. I'm sorry, I know I can talk fast sometimes, but if there are any questions, we're happy to have them.
Thank you, Caitlin, for a wonderful presentation on integrated mental health and looking at partnerships, care coordination, increasing access to care, and also telehealth. We do have a question for you, and please, if you have any questions, please feel free to type it in the Q&A box. The first question is, what are your billing/business models to support mental health in schools? Wondering if you are using any BHI/collaborative care codes.
That's a really good question. And I will say it has changed this school year. So I will do my best to answer, but it is a work in progress. Historically, we've only billed for family, individual, or group sessions. We've not billed anything beyond that. For a while too, we were in a position where we did not collect copays or any type of funding from families, but with some regulations we ran into this year, that has changed. But we have not found a way that feels ethical or right to bill for those other things at this point.
Thank you. The next question is, what locations do you operate in?
So we are in, I think it's 180 schools right now. Some of those schools we have just behavioral health or just dental, and some of them we have everything from medical, behavioral health, and dental. A lot of times it has to do with space as well as what the school needs. But we are all throughout Connecticut. We do have a few programs with CHC in other states, but not school-based at this point.
Thank you. The next question, how do you ensure patient safety when conducting sessions where the patient is at home?
That is always an interesting one, and it's definitely changed based on the age of the student. Sometimes, if they're younger, you've got the parent right there that signs them on, and usually we'll kind of check in and then leave for the session. We always have families contacts. That I know of, we have not had an issue where we've been concerned to the point of having to call an outside agency, like we use 211 in Connecticut, or the police to go and check on a student. But if we were in that position, we absolutely would.
Yeah. And the next question is, how do you determine which provider gets assigned to each school? Is there a process to determine the days they will be assigned at the school?
Yes, that's a great question. So usually what we do is we list what open positions in schools we have in like online as opposed to positions. We take a lot of time to figure out kind of based on how big is the school's population. Sometimes the schools will kind of have an idea of how many students they think they would refer. And we kind of guess on what we think the need is. Do we think we need someone full-time there? Do we think we need someone part-time initially, and hopefully they build to full-time? But we kind of assess both what the school needs and then list that as a position. So the provider coming in kind of can look at the list and pick what school they're hoping to be in. Does that answer the question?
I believe so. Thank you. The next question we have, does your state permit students to access mental health care without parental consent? If so, how do you navigate that?
So it does. This has actually been something we've looked at in the last probably year or two. It's been more on the forefront because we've had school districts who come and they really don't want that. They're very concerned about it. And then we have some areas who really want that. Based on our contracts with schools, we are not allowed to see students without the parental consent and take on form. So even with the state requirements, that would then make our contracts out of compliance. So because of that, at this point, we do not see any kid unless there is the parental consent on form. Now, obviously, if a school came to us and they had a kid that was suicidal, we would try to help step in and make sure they were safe, but we don't do ongoing therapy at this point without that.
Thank you. Do you work within the communities outside of the school?
We do. So most of the areas we have some rural schools that this isn't true for, but most of the school areas we work in, we also have one of our main sites, which is where we house like medical. Our psychiatrists often are at main sites, so families can go to those as well. Some of our rural sites, it's a little bit harder because they're further from a main site, but we always try to connect them, especially if they need to see a psychiatrist. We will refer to them at the main site. And the psychiatrists do a lot of telehealth, but we try to kind of keep them all connected that way.
Thank you. And what do you do during pupil-free days or if there is testing happening at the schools and students can't be pulled from class?
So our staff, our providers are on 195-day contracts. And so that when there isn't school in session, whether it's summer, they do work some summer days, or there's a snow day we just had up here, or a school holiday, our providers are off. Now, the only time that doesn't happen is providers work the day before school, the day after school. They're allowed 2 like team supervision days. So those might happen on days school is closed otherwise. Or they can use like one of their continuing ed days, but for the most part, we are off when schools are closed.
Thank you. And how are the LPCs supervised while they work towards their LCPC? Are the LCPCs in-house?
So right now, yes, we do have all of our supervision in-house. And I think that has been a newer state requirement too, that if you are an agency like us and you have unlicensed people, you have to provide the supervision. So we are providing it. Up until now, we had kind of assigned a supervisor, and they were the ones meeting with them weekly and individual, and then having them come to their team group supervision as well. We have found that that was not adequate enough. So right now we're in the process of building out a supervision model where we have hired somebody who full-time, this will be their job. Like they will develop the program, but it will include individual supervision, group supervision, as well as training seminars that we do, because we do them for the postdocs right now. And it can be different topics, it can be different modalities, it can be different interventions, but we're including that as a part of their process and getting their hours. So once they kind of come on with us and they're not licensed, they will enter into this program and be a part of that as well.
Thank you, Caitlin, and thank you all for your great questions. I would like to share a few announcements with you before we conclude today's webinar. The School-Based Health Alliance is seeking new members to join our Youth Advisory Council as ongoing efforts to amplify the voice of youth in school-based health care. Applications are open until February 29th, 2024. If you are interested and would like to learn more information, please visit our Youth Health Hub website. Also, please save the date for the 2024 National School-Based Healthcare Conference to take place June 30th to July 2nd in Washington, D.C. For more information, please visit the School-Based Health Alliance website. And the School-Based Health Alliance website. I'm sorry, I thought you had one more question. Please visit the School-Based Health Alliance website. And again, I would like to thank you, Caitlin Warner, for a wonderful presentation on integrated mental health. And thank you all for joining us today. If you have any questions following today's presentation, please feel free to contact us at info@sbhforall.org. Also, a copy of today's slides will be available to you through email, as well as a recording of the webinar. Also, a recording of the webinar will be available on the School-Based Health Alliance website, in addition to the Health Center Resource Clearinghouse. At this time, we ask you to please complete an evaluation poll of today's webinar. Again, thank you for attending today's presentation and have a good remainder of your day. Thank you.